Good afternoon, everyone. I decided to give a talk today about transgender care. And the question is, why do I pick this group of people to talk about? Can you all hear me? Okay. So it is basically because we know that infertility as a problem has been neglected a lot. But if there's a group that is neglected the most, it is the LGBTQ community and the transgender people. So today I want to be part of the healthcare providers that actually give them the options of their reproduction. So we know now that gender is no longer defined as previously defined as a male and a female. So we have all shades of people. The nomenclature changes from time to time, and we need to be up to date with all the nomenclature. A year ago, it was LGBTQ. Then I heard last year it's LGBTQIA+. So now you can see there's more options. But you need to know that there are lesbians, there are gays, there are bisexual, there are transgender. There's another T that has been added now, transsexual, there's queer, there's those that are questioning, and you just need to know the nomenclature, and you need to refer to the persons, the LGBTQ, with the right nomenclature. Again, the terminology is important because a transgender person is a person whose gender, the identity differs from what they were born with, the sex that they were born with. So once they know what they want to be identified as, they will want to transition into the one that they identify with the most. So if they are trans men, it means they are transitioning from a female to a male. If they are trans women, they are transitioning from a male to a female. And it is important also to no longer refer to them as him or her, and the right way to refer to them is them, they, or their. So because of this whole process of transitioning and the fact that they are still trying to identify, and there's a mismatch between the gender identity and what they were born with. They have a lot of mental issues, they seek mental health, and they have to transition in their social environments with their friends and their families, and they experience problems there, and the support is lacking from their friends and their family during this period of transition. As such, you find that they have a lot of depression, a lot of anxiety, and we are not helping much because with the waiting periods for surgery, that causes them further anxiety. This study that was done in the US Transgender Survey showed that 40% of the people that responded to the survey said that they have attempted suicide at some point in their life. And this is compared to 4.6% in the general population. 48% have seriously thought about killing themselves. 82% had serious thoughts in that 1 year. And 24% of the respondents have actually made plans to kill themselves in the past year. 7% have actually attempted suicide in the past year. 71% have done it more than once, and 46% 3 or more times. So we can see that this is a serious problem. So what do we do to make sure that these patients are in a welcoming environment? Is to make sure that our clinics are a safe and welcoming environment for them. What that means is that we need to train our staff to identify these patients from the onset. that they make sure that we know that these patients are transgender. We have forms there at the bottom that now must be part of our clinic. They no longer must have only the section of male and female. We must have other options so that we know what to refer them as. And again, we must ask them if they have had any surgery, or if they've transitioned, or this is the sex that they were born with. Our waiting areas must be inclusive. The kind of materials we put there for them to read must be inclusive. And our bathroom, we need to really move now to gender neutral bathrooms. There mustn't be a male bathroom and a female bathroom. It must be gender neutral so that the transitioning person is not confused which one to go to. And often the identity, the name on the identity document is still the name that of the sex they were born with. So if I made an example earlier of Bruce Jenner, we know him from the Kardashians. He transitioned into Caitlyn Jenner, but if the ID still says he's Bruce Jenner, when it comes to our clinic, we cannot say to him he is Bruce Jenner because he has changed. He's now Caitlyn Jenner. So we need to ask when they come in, what name do you prefer to be called by? So that we document that on the file, and that is the name that we must now call them. When we do physical examination, we need to be aware that this is also anxiety causing to them. So firstly, again, we call them by the name of their choosing, the one they want to be called by. They have particular body parts. They might not like that it is a penis. They might call it something else. We need to find out what it is they prefer us to call the body parts. Again, some of them will bind their breasts because they want to look like male. So we mustn't be shocked or surprised when we see things like that. So some of them will tuck the penis, put it away so that they look more female than male, look more female than male. And when there's a patient with a neo-vagina, what has been created for them as a vagina, you must not take the biggest speculum and go and put it in there because it's still small, it needs to be dilated. We have to be sensitive about all of these things. So this is what will reduce the anxiety of the examination. Now, when we get to gender affirming treatment, what is it there for? We first use hormone therapy. Hormone therapy for the female will help us with clitoral enlargement, will help us with the facial hairs to feminize them, and the tracheal cartilage, when they've got an Adam's apple, can be shaved so that it's smaller, they look more feminine. The voice surgeries can be done, and breast augmentation can be done. To masculinize, also hormone therapy can help us masculinize the chest, and then we do mammoplasty, make sure they've got a flat chest. We will remove the hysterectomy or oophorectomy, remove the uterus. I will show you that later about the surgery for gender affirming treatment. So firstly, what is the process? The process is that a diagnosis is made and the patient will go and see a psychiatrist to make sure that this is not a psychological problem, that they actually there's a mismatch between the gender that they identify with and the sex that they were born with. After a diagnosis is made, then we start the hormonal treatment, the medication to either make them male or make them female outwardly. And then goes to the surgery. This is the gender affirming surgery where we either remove the penis and give them breasts to make them more female. And then the hormones have to continue thereafter. But this is where now we as fertility specialists can intervene. Before they start with the hormone therapy is when we should actually be discussing their fertility options. what they want in future. Do they still want children? Do they not want children? Because this is where we can start freezing their gametes, either the sperm or the egg, before they start hormone treatment. But if they have already started the hormone treatment, we have to intervene before the surgery. As I showed you earlier, the surgery, you remove everything if they are transitioning. So we can actually store their gametes before then. So we can stop the hormone therapy, stimulate them, or they freeze the sperm, and then they can go on to do the gender affirming surgery. So the hormone treatment, if it is supposed to be viralizing, meaning turn a woman into a man, what happens is that the breast must go away. So we need to decrease the breast tissue. We need to make sure that they stop menstruating and increase the clitoral size and increase their sexual desire. Although I don't understand why they think men have more sexual desire than women, but nonetheless, make sure that there's less sexual desire. And then you need to increase the facial body hair and make sure that the pitch of the voice is lower and the muscle mass must increase. And to do this, we use testosterone. Testosterone will help us develop the facial hair and the voice changes and increase the muscle mass. Will promote clitoral growth and cessation of menstruation and increase the libido. Those that are transitioning, again, from a woman, sorry, I went back. Transitioning now from a male to a woman, we need now the opposite. You need to increase the breast tissue because you need to make sure that they've got breasts. You need to increase the softness. You know, their skin must not feel like a man when you touch them. You need to decrease the penile erections, decrease the prostate size, and decrease the sexual desire. Again, you decrease the facial hair. The voice, there may not be much change, but there is surgery that can be done for the voice. And you need to decrease the mass, the muscle mass. And to do that, we use anti-androgens because the hair must go away. So it will reduce the male pattern hair, it will reduce the muscle mass, change the sweat and odor patterns, decrease the erectile function, and again, you want to develop the breast and redistribute the subcutaneous fat. The surgery that is done in a stepwise fashion. The first step, there's counseling with a psychologist and a psychiatrist evaluation. This is followed by living in a role. So they have to live as the other sex and see if that is what they want. So they have to be sure before we do the surgery that that is the sex of their choosing. Then comes the sexual hormone treatment for secondary sexual characteristics. Then we reevaluate after 6 months of that. After that, you do the surgery. The surgery, changing from a male to a female, we start with the bottom surgery. So it's penectomy, removal of the penis. After that, 6 months later, we create a neo-vagina. So we have to create a vagina for them. And then they have to dilate this vagina because we don't want it to be fibrotic. After the dilation, then we have to create a vulva. So it's a vulvoplasty. So this may take a couple of procedures and it's 6 months after they've dilated. So to change from a female to a male. So the bottom surgery, again, hysterectomy or oophorectomy. And this is why we say we must preserve the gametes before they go to surgery because we remove the womb, we could remove the eggs, and then vaginectomy, we lengthen the urethra, and then create a neopenis. So far, the surgery for neopenis is not very successful. There has been one patient that they said was successful in Stellenbosch, but we keep on trying, and hopefully we will get there to create a neopenis. Then the top surgery, you remove the breast and with a mastectomy. Unfortunately, this surgery in the public sector is done only at Steve Biko, and I think that UCT Grooterskloof does it. But because of that, the appointment waiting times at Steve Biko is 3 months, and at the moment we're only seeing follow-up patients. There's no new patients. And the reason is that there's too many patients on the waiting list already. You heard the MEC this morning saying that the waiting list is very long. So the number of surgeries that can be performed per year is 4. And this involves the gynecologist, the urologist, and the plastic surgeons. And at the moment, this is the number of patients that are waiting just for the penectomy, which is the first step. It's 40. And if we're operating 4 a year, you can do the math. So the waiting time for surgery ideally should be about 2 to 3 years, but at the moment it's about 10 years. So many of these patients, they come to our clinics and they ask about their fertility options. And you can see in that study, it says that 38% of men would have loved to have been offered to store their sperms if they had been counseled for that. And 54% said that they desire biological treatment, children. So in a sense, by not offering them the fertility options, we are actually taking away their desire to be parents and to have biological treatment. So we need to start offering treatment for them. So that study by Reproductive Health showed that 95% of the participants said that the healthcare provider should have actually discussed this option with them. So they missed the boat because it was never discussed with them. They actually now have transitioned without having cryopreserved or frozen or stored any of their gametes. So now the ASRM, the American Society of Reproductive Medicine, and the European Society have issued a statement that transgender patients should have access to fertility options as any other person seeking fertility care, and fertility preservation should be discussed before the gender transitioning. So what options do we have? So before the hormones or before the surgery, we can store the eggs for those that are transitioning to men, so they are female. So we can store their oocytes. We can store their embryos if they've got a partner, they want it fertilized and stored as an embryo. Or we can store ovarian tissue. So if then later in life they want to use their gametes, those that have a female partner can use the oocyte and put it together with a donor sperm and then in the partner's uterus, okay? And if the partner is male, it means that you will need a sperm and you will need a surrogate. So these are the options for those transitioning from female to male. And those transitioning from male to female can have their sperm stored or the surgical extraction of the sperm. And then if the partner is male, they will need a donor oocyte and a surrogate. But if the partner is female, then we can do the normal IVF options of IUI, IVF, or ICSI. So in conclusion, I'd like to say that transgender care is a human rights issue and should be approached in a rights-based approach. And we all have our rights to our reproductive choices, and we should always provide comprehensive care for everyone, including the transgender persons. And as in the United Nations commitment or pledge, we want to leave no one behind. Thank you everyone for listening.